As far as some of the basic anatomy, just to kind of a little refresher course, this is looking at the low back, and so we've got the lumbar vertebrae, and we have the spine. This is kind of a wimpy laser here, but we have the spinous process. And the lamina here, so when we're doing a laminectomy, that's where we take away the center part of the bone here over however many levels we need to. Off to the side of that is what are called the facets, so those are the joints, so that's where your spine sort of articulates. These are important. First of all, they can be a source of pain just from arthritis, but they're obviously important from a stability standpoint, so when you're doing a laminectomy, you want to make sure you stop at a certain point so that you don't get into the facet, because then you can just be creating, more problems than you started out with. Looking at it from the side, vertebrae, you can see the discs, spinous process and lamina. Again, here are the facets. Important thing to kind of appreciate here, and there'll be some other pictures, is what's called the neuroforamen. So that's where the nerve roots come out at each one of these levels here. And this is a particular area where the nerve can be compromised because it's all surrounded 360 degrees by either bone or disc. So as the disc and other things collapse, that can create problems. I was going to say something here, but... And then this is just meant to kind of show that, there's a lot holding the back together that the evaluation and diagnosis of is kind of even beyond what we can do now. I mean, MRIs can look at discs and nerves pretty well, but when it comes to looking at all the ligaments and things that hold the back together, we're still, we really just can't evaluate any of that stuff at this point. X-rays don't show it, MRIs don't show it, and so, there's a lot of people that can have back pain problems, their MRIs look fine. What's the explanation? Well, it's probably some other kind of structure in that area that we just can't see. You've got ligaments that are kind of holding the disc and the annulus together, anterior longitudinal ligament that runs up and down the spine. You've got a posterior longitudinal ligament. In between each of the spinous processes, you have ligaments. And then you have facet capsules around each of these facet joints. And people can pick up and strain their back and hurt something, and their MRI can look pretty normal, but they may have done something to one of these soft tissue structures. And then you have the disc. I think everyone probably remembers from basics that you have this inner part that's called the nucleus. Nucleus is, when it's young and healthy, it's really like tire rubber. It's a very tough structure. It's not like jelly or something like that. And then you have this outer annulus, which is a very fibrous, tough, cartilaginous type structure. And when you're younger, you have this nucleus is well hydrated, so it shows up a little bit different color on MRI scans. And then as you get degenerative changes, which starts out as the disc drying, then you can start to see that on MRIs as you lose the water content. And then as it says here, the water content decreases with age, with your best being at about age 30. So I'm working on that. And then this kind of shows that progression we were talking about. So here's your young, healthy disc, nice and thick. You've got that inner sort of healthy nucleus there, and then that's what it looks like on the MRI scan. So bright color, that's water content. And then you can see as the disc ages, starts to lose its water content, so your disc gets darker. And then as it loses that resilience, then it starts to collapse and gets narrower, and that's kind of the progression of this degenerative disc disease. And it's because of a lot of different things, but it's just aging of the disc. And then this goes back to what we were sort of talking about, is how this whole process then can lead to problems in the spine, because as the disc loses its height here, you can then see that the neuroforamen is going to shrink in size, and so a lot of people will come in because they're starting to get leg pain, and the leg pains come from the fact that that tunnel has just gotten narrow enough now that they're starting to have problems. Not only does the neural foramen get narrower, but then it starts to put more pressure on these facets, because normally the disc is thick and those facets are kind of held open, but as everything settles, then the facets start to get more and more pressure on them, and that can lead to, you know, other problems with sort of chronic back pain issues. So there are a lot of people that have facet pain, for instance, and that's the difficulty of back pain, is trying to figure out what kind of, where their pain is coming from. Is it coming from the disc or ligaments or facets? So there's lots of different things we do to try to figure that out. As far as cervical, we kind of head then into some of the conditions, just real basic cervical conditions. Obviously, people are going to present with basic symptoms. They might have neck pain, shoulder blade pain. Shoulder blade pain is very common for a lower cervical condition because a lot of the lower cervical nerves refer pain to the shoulder blade. So people come in, their shoulder blade hurts, they think they have a pulled muscle or a thoracic spine problem, and it's really a cervical problem. Obviously, arm complaints, numbness, tingling, pain, coordination problems, walking problems. That's when we're getting more severe. That's usually it relates to cord compression, or what we call myelopathy. And then obviously if you have neck strain, neck problems, that can lead to headaches, and then you have weird complaints that can come from other bizarre neck problems like fever, night sweats, people with abscesses, or other bizarre things that we sometimes see. And then, you know, obviously signs that we look for, there's motor signs. So you're looking for, you know, weakness, and you guys test that. If it's prolonged, you know, they can start to develop atrophy. Obviously numbness, and then reflex changes. And reflexes, you know, I think the important thing there is we tend to look for, there's different types of abnormal reflexes. There's asymmetrical reflexes. So someone has a good knee jerk on one side but nothing on the other side, that's probably clinically important. Or increased reflexes. A lot of people come in saying, well, I don't have reflexes in my knees, and but that's kind of normal. A lot of people, as they get older, they'll kind of lose those reflexes, but it's when it's different, it's good on one side, not on the other, that's when it becomes a little more important. Or when you get hyperreflexive, which is again a sign of myelopathy or cord compression or some sort of spinal cord problem. This is all when we grade motor testing. This is just sort of the scale we use. I don't know if that's something that the nurses use typically to grade, but if you read our notes, it always says 5 out of 5 or 3 out of 5. And this is how we grade it. So 5 is being normal. 4, you know, is, I guess, you know, slightly weak is a way to look at it. 3 is getting pretty weak. You can go against gravity, but not really much more than that. 2 is you can't move it against gravity. So if you hold the limb in a certain direction where they don't have to raise it up against gravity, but they can still move it, that's 2. 1 is trace, and then 0. So, you know, that's kind of how we grade weakness. And this is kind of the one important thing. This is kind of one lesson I want everybody to kind of take away from this, is looking at each kind of specific nerve root. Because each nerve root obviously does a different thing. And so if we're doing a C4-5 anterior cervical discectomy infusion and we're working around the C5 nerve root, we're not going to really be worried about motor issues with C8. I mean, if we are, that's, you know, they're obviously having a big problem. So we're interested, obviously, with that. So these are kind of the important things to sort of think about. So if somebody comes in and they have a diagnosis of a C7, C6 radiculopathy, this kind of helps you sort of figure out where should I tailor my exam. So C5, that's a nerve that goes to shoulder abduction, okay? So that goes to the deltoid. And so obviously we're going to have patients test that by raising their arm up. So if somebody comes in and you read in their note that they have a C5 radiculopathy or they've had a C4-5, that's what we're really interested in. So, you know, if after surgery in the recovery room, you know, they had normal deltoids and now they can't move their arm up, you know, obviously that's the important part. They may be squeezing their hands fine, you know, so you may test their strength and in their biceps, which all may be fine, but if it's C5, you got to be testing the right muscle group. C6, next nerve root down, that has to do more with biceps. We're talking about elbow flexion, okay? And it also does wrist extension. So again, you're mainly testing biceps. C7, triceps, so arm extension. And the other way to test it is finger extension, but again, mainly it's arm. And then C8 tends to be a little more either thumb, or a lot of times we will test just grip strength. So, you know, your post-op spine patient, you're testing their grip, you're really testing kind of C8 kind of things. But if they've had a C5 surgery, you know, that may not be the right thing to be testing. You're obviously get knowledge that their spinal cord is working, you know, which is good, but you're not tailoring your exam to that particular spot. And then other parts of the exam, as we talked about, there's sensation, like touch, reflexes, and these are other more clinical findings that we have before surgery. There's what's called a Spurlings, which is where you do a maneuver to basically compress the foramen down and see if that elicits the pain. So you may see that in H&Ps, or Lermite sign, which is a sign of spinal cord compression. And that's when you get this lightning shock that shoots up and down your spine when you move your head, and that's some type of intermittent spinal cord compression. Okay, lumbar, back pain, number 2 problem bringing people into the office. Obviously they can have leg complaints, same as the arms, so pain, numbness, weakness, you know, dexterity, coordination problems. And then this is where we start getting into other issues that we can sometimes see, such as loss of bowel or bladder function. The lower sacral nerves control sphincters that allow you to control bowel and bladder. And so when people have some problem that's either affecting the bottom of the spinal cord, called the conus, or all of the sacral nerve roots, which we call Todd Kuether syndrome, which you've probably heard of, then people can have this. Sorry. I was in Miami a few weeks ago. So that's left over. Okay, so it's actually pretty rare. I've only seen probably 3-4 people in the last 12 years or so that have had a true, like, Todd Kuether syndrome. You see a lot of people that come in that's, you know, they've had some sort of bladder incontinence or whatever, and they get all worked up, and that's the right thing to do, but very rare that we truly see a huge disc herniation that results in it. Usually it's more of a pain thing. You got people that are so painful, they're taking narcotics, their bladders are probably getting distended, they're not functioning correctly, they're spending all day laying down, and they start to get either some, you know, urge incontinence or overflow issues or something else going on. And then obviously same signs in the lumbar spine: weakness, numbness, reflex changes, etc. Going back to motor function, you know, there's basic dermatomes, so, you know, there's sensory distributions for each nerve root. So more of the L1, L2 tends to create pain, numbness, tingling more up in the hip area. L3 tends to be more in the groin, so people come in with groin pain. L4 tends to be more sort of down the thigh, quadricep, knee, down the front of the leg. L5 more down the side of the leg. S1 more down the back of the leg, and that's kind of what we call sciatica. So sciatica really isn't sciatica. You know, the sciatic nerve is a nerve that's down in the leg. So, but that's what people call it, and most of the time people have pain going down the back of their leg. It's an S1 radiculopathy, not sciatica, but, you know, that's just kind of the lay person's term. Probably don't need to know this, I'll just mention it. Waddell signs is something that we look at clinically before surgery, and these are basically to try to figure out if someone's malingering or not. So we see a lot of, you know, whether it's automobile, workers' comp, or other people that have some, you know, people are a little crazy. that have some reason to be embellishing or doing something. There's a bunch of different signs that tests that we can do to try to figure out if that's what's going on. And it has to do with, their pain behaviors, or, are they jumping anytime you just put a finger on them? We do certain maneuvers where, we grab their hips and rotate their whole body, which isn't doing anything to their spine, but they'll complain that, you're hurting their back, and all we're doing is just kind of rotating their whole body in space, which really shouldn't be doing anything. Putting pressure on someone's head, just putting arm pressure, and that's not really enough to produce any, changes mechanically in your spine, but there's some people, that will buckle under the pressure, and, certain things to distract people where, you try to raise a leg to elicit pain, called the straight leg raising, and, while they're sitting there, you can barely get it up 5 degrees, but then you do something else, or you have them get off the bed, or you check the other leg, or you say, can you put your foot up here for a minute on the stool, and they put their leg up there fine, and you kind of know that there's something going on. Things we look at, obviously basics, x-rays, obviously is going to look at bony anatomy, spurs, fractures. We can see the foramen here on these oblique views to kind of get an idea if there's anything going on there. MRIs, so MRIs are going to give us a good look at the discs, the spinal cord, but that's about it. We're not seeing those things that we talked about before, like the joint capsules and ligaments and all those things that can potentially get strained in automobile accidents or injuries or other things. But we can see disc protrusions. For instance, this person has, you can see, for instance, this disc here is kind of protruding back a little bit. And then the other kind of basic thing we sometimes use is what's called a CT myelogram. And so that's where they put dye in the spinal fluid and then get a CAT scan. It's a good test in terms of not only showing bone, but it then shows kind of filling defects. So here's the disc here, here's spinal cord. Same thing here, here's spinal cord, and there's the disc. But it's kind of an invasive test, so I usually don't do too many of these unless you have to. And then these are all, I don't think we need to go into these specifically, but, I think in general, these are going to be the majority of the patients that, you're going to be seeing when it comes to cervical. We've got patients who are either having, an ACTF or a fusion to deal with some of these problems. I do a lot of posterior surgery, like Dr. Rosenbaum does mainly, which is more going through the back and doing foraminotomies instead of doing a fusion. And if you guys have questions about why one or the other, we can certainly get into that, but a lot of it has to do with what surgeons are comfortable doing, what the anatomy is, what you're trying to fix, and certain things have, the right choice of procedure. And then there's disc arthroplasty or disc replacement. We don't do too many of those, mainly because it's an insurance issue. Most insurance companies don't cover them, consider them experimental. And then laminectomies, where we're removing the lamina. That's usually done in more elderly patients that have stenosis or compression of the spinal cord, and you're just trying to relieve pressure of the spinal cord. Lumbar, we got simple microdiscs, laminectomies for stenosis, or then we get more into fusions for people with instability problems or other things, and disc replacements, which again we don't do too many of. The thoracic I have up there, it's pretty rare we do thoracic surgery. I mean, occasionally for, a big disc herniation, but it's very, very uncommon. And this, I just threw up a couple slides. These are kind of some of the things we're doing. This is what's labeled an endoscopic fusion. We don't really use endoscopes, or I don't use endoscopes, but we do these surgeries all through basically these little tubes. And so, basically they have devices now, instruments that we can work through these little tubes. We can get a decompression of the nerves We can put in a spacer into where the disc used to be with bone-growing substances to produce the fusion, and then we can even put screws and rods in down through these little tubes. And so there's been a few patients that we've done here that we do kind of with minimally invasive option where we'll do little, you'll know that because they'll have small incisions on each side rather than the little bit bigger one in the center. So they've had a less invasive kind of approach from each side. This is something that we've done a reasonable amount here called an X-lift. So that's a different type of fusion that goes directly through the side. And the nice thing about this is that there's, because we're not going through the back muscles, we don't have all that post-operative pain and recovery that comes from, disrupting all of those structures. And this just kind of shows that this has really been the one procedure, I think, because I've done a lot of different fusions, endoscopic fusions, minimally. This is kind of the one fusion that I can really say has been kind of a night and day difference between the whole other patient category. I mean, these people come in, and I would say a lot of them could probably get out the door later that same day. We usually keep them, and I would say at least here, probably 90% of them have gone home the next day, which we've never see in a regular fusion. Those are typically 3 days or so. But this is the one group where people have really done well compared to other patients. And the X-lift is basically going through the side. It allows us to basically put in a big spacer, and we don't really even work around the nerves at all. And so the way this works is that just by opening that back up, we distract those tunnels. All the ligaments that are kind of buckled in back there get stretched out and create more room for the nerves. So it's kind of indirectly decompressing all of those structures back there. And it's done through this incision on the side that doesn't go through really any muscle. And so that's why people do well. This is something I wanted just to touch on, and everybody I think is probably pretty familiar with this, but occasionally you'll see people with lumbar drains. Why do we put them in? Well, sometimes usually they're intentionally put in when we're going through the dura for whatever reason. So if we have to go into the spinal canal and either go to the spinal cord for a tumor, then we might have to open up the dura, and then we stitch it up, and we've got this, kind of leaky suture line. So to keep this CSF from pouring out of that repair area, that's why we put in a lumbar drain to divert the CSF a different way so that area can kind of scar and seal up. People sometimes during surgery, routine surgeries, can get tears in the dura, and they can get spinal fluid leaks. Normally, during surgery, we put caulk, basically, to try to seal those leaks. It's a fibrin glue. But if they come back and they get recurrent headaches and recurrent leaks, then sometimes we have to put in lumbar drains, again, to try to get the pressure off that area and allow it to heal. So that's kind of why you'll see them. As far as orders for the drain, everybody kind of has a different way of doing it, so there's no standardized, but normally you'll see that one of two things. They'll either want the drain open at a certain level, and it'll describe the level as, 0 centimeters or 10 centimeters above some structure, whether it's the tragus or the brow or something. So you'll see, the lumbar drain open 10 centimeters over brow. Or you'll see like a flow rate. Some surgeons want it drained a certain amount, so they'll say drain 10 cc's an hour. So they'll want you to, lower the drain, open it up, wait for 10 cc's to come out, close the drain, and then wait for the next hour. I tend to be kind of just leave it at a certain level. Care of the drain, the biggest, they've looked at studies to look at infection rates for these sorts of things, and the biggest issue with infected catheters has been, one, the time that they're in place, and two, how many times it's messed around with, how many times the stopcocks are opened or CSF is sampled. So it's kind of one of these things, the less you can kind of do with it and mess around with it, the better. So generally speaking, there shouldn't be a whole lot of care. You shouldn't have to change dressings or other sorts of things. And in general, we prefer not to do those sorts of things because that's when they get pulled out. And we usually try to tape them in so you can hang from them. Length of use, typically lumbar drains are in for about 3 days. Hopefully the leak stopped. We then clamp it for usually a day, and then if their symptoms are resolved, then we take it out. This is one thing as far as just basics for you guys knowing. Disconnection. What do you do if a patient comes in and it's disconnected? Well, it'd be nice to say, yeah, we can just easily just insert a new one. In general, if they're close to potentially getting it taken out, we may just say, put it back together and clamp it off, and then we'll pull it out. Occasionally, we'll cut the catheter and reattach it. But obviously, if it's been disconnected, then there's a potential for introduction of bacteria. So probably what it means is relatively soon we'll pull it out. But it's something that you just have to call us, and we can give you advice as to what would need to happen at that point. What do you do if there's no drainage? This is important just because the whole reason that it's in there is to be draining and to be taking spinal fluid out so that we don't have pressure at that site. So if someone has a lumbar drain in and goes 8 hours with no drainage, that's something that we should know about, because at that point it's not doing anything. And it could be because it's plugged or twisted or the patient's laying on it funny or whatever, but that's important to know. And then you've all seen probably what the lumbar drain looks like. The key here is that there's a scale that usually has 0 to whatever number, and usually it's centimeters of water. There's different ones. There's usually like millimeters of mercury and centimeters of water. We usually do the centimeters of water. So there's this scale, and then on this chamber, which is where it's dripping out up here, there's an arrow which usually says 0. And that's the important arrow right there. So what we'll usually do is it says that we want, let's say, the patient to be at 10 centimeters over the EAM, or external auditory meatus. So here, this patient has, it says 0 here, let's say. So this patient is zeroed at the ear. So the scale here, 0 is at the ear, but then we want them at 10 over the ear. So this arrow is then going to be set at the 10 mark. That's just kind of the basics. So that, like I said, all these things can be different. It could be zeroed at the brow and then 10 above brow. So you'd zero that, 0 here at the brow and then raise that up. It could be 5 above the brow. So you'd have 0 at the brow and then raise that to the 5 mark. So that's kind of the basics there. Any questions? And obviously that's important with the bed. That's one of the biggest things, Everything, the ventric or the lumbar drain set up perfectly, but sometime in the last 2 hours, the patient has gotten out of bed and their bed is a foot higher than it was before, and something's wrong with the drain. And it's usually okay to clamp it, let the patient go up to the bathroom. So if there's a problem, it's more when they get up and it's unclamped and all this fluid drains out, then they can get kind of a bad headache. But I've never seen anything bad happening from too much drainage. Okay, as far as discharge instructions, wound care, obviously everybody has their own things. On outpatients, I usually don't. We put special dressings on them in surgery so we don't have them changed before they go home. They go home with these waterproof bandages on so that they can take a shower. Most of my patients don't need any kind of Tegaderm or what's the clear stuff? Opsites to cover it. I usually have them keep their incision dry for 2 days and then they can shower. So if it's an outpatient thing, they usually have a waterproof Band-Aid or bandage on there that they can shower with it on, take it off in 2 days, and then they can get it wet. In the hospital, they have staples in, whatever. Dressings are on for 2 days, change if you need them, but then in 2 days they can take them off, shower, get the staples wet, just pat it dry. We usually don't like any kind of ointment or other things on them. DVT, this is something I just bring up. We don't do it here, but it's something that would be interesting for people, especially in charge of the units, to consider. But they now have take-home DVT pumps. They're really neat. They're just this little pump. It's like, it's about this big, and it comes with like booties. And patients can go home and they take this thing home, you write for it, insurance pays for it, and then it comes with its own little mail back envelope